following is a conversation. It has the features of any conversation, such as imperfectly expressed thoughts, ill-considered opinions, and the notions of several sleep-deprived brains. Try not to get your stethoscope in a twist about it.
On today's show, we're talking... That's not right. I didn't... On today's show, we've got some M4s talking about their experiences on the interview trail, their specialties, all that kind of stuff. But first, how's it going?
Good.
Yeah?
Yeah.
You're approaching the end of your med school career. Does that freak you out at all? Are you excited?
I'm horrified. I don't know about you guys.
You get to start like actually signing things.
I know.
Yeah, a lot of paperwork. And so it's just been this struggle between trying to enjoy the remaining time we have of M4 year, but also knowing there's like a lot of things looming. And
yeah, 'cause it's funny. On the one hand, you're like, oh, great, I made it. I got my match. I'm ready to go. And then on the other hand, this school is being like, and your future jobs are being like, okay, now fill out all this paperwork and do it now.
Yes.
Oh, and look for a house.
yes.
Yeah, moving is not fun.
Yeah.
I don't know anything
trying to buy
about
a
it.
car. Like you're all of a sudden you're like, oh, I'm gonna pack all this adulting into the last few weeks of med school.
Meandering in the margins of medicine, it's the Shortcoat Podcast.
Weird news,
fresh views,
helpful clues, and interviews.
by students, for students.
Subscribe to our weekly show at theshortcoat.com.
Welcome back to the Shortcoat Podcast, the show that gives you an inside look at medical school from the students drinking from that fire hose. It's a production of the University of Iowa Carver College of Medicine. I'm Dave Etler. With me today in the SCP studio, a bunch of M4s, graduating senior medical students, nearly residents. Holy crap. Good job, guys.
Thank you.
We've got Matt Engelken.
Howdy.
We've got Jacob Lamb.
Hello.
We've got Mallory Kallish.
Hi.
We've got Will Sai.
Hey, everyone.
Welcome to the show. Yo, Shortcoats. Sup, bros? I need your questions, your comments, your ideas. Go to theshortcoat.com/tell us and send them to me. I'm voracious. I'm ravenous for your questions. So, get her done. Help me out. Okay, match week, as we've said in previous episodes, is a crazy time. You guys all kicked ass, I assume. I mean, there is soap, but I don't know if that was a factor for you guys, and I don't want to know for the purposes of this episode. But let's start by going around the room. What specialty did you match into, and what part of the country are you off to? Let's start with you, Mallory.
Alrighty. I matched into general surgery, and I'll be heading to Nebraska for that.
Badass.
Yeah. I'm excited.
Matt?
I matched into OBGYN and I'll be going to Mercy Hospital in St. Louis.
Your turn, Will.
I match into family medicine, and I'm headed to St. Joseph Hospital in Denver, Colorado.
Nice.
I matched into diagnostic radiology, so I have a transitional year in South Dakota and then residency in St. Louis.
Sweet. Okay. Well, I'm glad you're all here to talk about your experiences in the last year-ish. Matt, what do you want to start with?
On the way into the studio, Dave, I walked past a bunch of M1s that are all doing MYHD3 or one of our didactic curricula.
Mechanisms of Health and Disease, 4 classes that you do basically from your M1 year to M1 and a half.
Mm-hmm.
So, it's the big one.
It's the
I feel
big
like it's
one,
the big one.
And it's the one where you sit down and you do test after test after test after test on, in my opinion, the most boring things in the world.
Immunology.
What?
Oh, I'm sorry.
No, okay.
And one thing that I know has been brought up on this podcast many times is, and something that I've related to as well, was, after these tests and after these classes, being like, I don't want to do this. Like, I don't want to do any of this. None of this is interesting. None of this is cool. It's just work.
I find it hard to believe that tests don't whet your appetite for medicine.
Well, if that was the goal, it did a bad job. And so I just remember being like, I don't know what I want to go into. I don't like any of this stuff. Like, I hoped that one day I'd wake up and be like, wow, this organ system's great, and I'm going to do this for the rest of my life. But MYHC 3, that just did not happen for me. And for you guys, did you have a similar experience? Was there something that jumped off the page and you're like, this is perfect? Or did it feel like a big old slog until you kind of figured out what you wanted to do later down? Yeah,
Matt, I totally relate with you on that. I remember being in the middle of first year during the preclinical phase, just feeling so tired and feeling so like, oh my gosh, like this Firehose is serious, and all these things we're learning. I felt like, man, like there was like so much to learn. It was so much work, and I wanted to go into medicine to talk to people, to build relationships, and to work with patients. And I think for me, I found myself having to keep remind myself to take a bigger picture perspective of like, okay, you know what, like I'm laying down the foundations right now, and these foundations are going to help me take care of patients better in the future. But it was a struggle. It was a battle each day, just like preparing for tests after tests. But I think it was very much that trying to take that bigger picture perspective that helped me survive through that season.
Yeah, I agree. I also think there's kind of like this pressure where like whenever you meet someone new, the first thing they ask you like, oh, what do you think you're interested in? And honestly, I think like anyone who thinks they know a lot of times is kind of full of it. Like there are some people who I think who come into medical school and are like, absolutely, I'm going to do this one specialty and that's all they do. But like, I did not come into med school thinking I was going to apply general surgery. I did not think during preclinicals, like I wasn't like some whiz at anatomy who like loved doing dissections. And so like I knew I was going to go into surgery. Like I think that all came really late. And there's, I think, a lot of pressure in the beginning when you're doing didactics that like something will magically just like jump out to you and you'll like know what you're going to do for the rest of your life. And for me, that was definitely not true.
Mm. Yeah, I'll offer a different perspective because I kind of like just learning and taking tests. I'm kind of weird like that. Maybe that's why I'm going into radiology, but nothing in particular was like, wow, I really love learning about this. But I think just more of the process of like just learning more, and like people will stress about tests, and I would stress about tests too. But at the same time, like after you get through it, you're like, I just did that. And
I would encourage people to adopt that attitude.
Yeah, that's a great attitude.
Great attitude.
Dread all the time.
Yeah. But also, like, if you just can't, that makes sense to me.
Going back to what you said, Mallory, I was also in a very similar spot where, I'm going into OBGYN, and there was I think 2 weeks of like solely OBGYN during this block. And during those 2 weeks, I did not think about OB at all. I didn't expect to go into it. Not that I hated the specialty, I just had no clue what it was, and I didn't think I was going to do it. It took me until the summer after my M1 year when I kind of went out into a local hospital and luckily had a really good OBGYN show me around. But kind of based on that, hearing your story of what maybe not having that light bulb moment during the years where everyone's talking about what research are you doing? Who's your mentor? What do you want to go into? And feeling that stress. When do you guys think that you started like developing your differential for what you wanted to go into, or if anything changed at all?
I don't know. I think it honestly took until I was on core rotations and I was able to like go through a couple and really start, comparing them to one another. Like I think that like I went to my first rotation, and just because we were like seeing patients and like out in the world and like doing things that actually felt meaningful, I thought I like loved my first rotation, and that was like what I was going to do with my life.
What was it?
It was pediatrics.
Okay.
But
that's a good rotation.
It was a great rotation. And like, I think I had a moment where I was like doubting surgery, and I did for a moment think about applying to peds. So it's not like a crazy thing, but I think kind of seeing a bunch of different specialties and being able to compare my experience in them really helped me kind of narrow down. And then once I did my surgery rotation and I like just loved that rotation, I think I spent every other rotation trying to talk myself out of surgery because surgery is not known for being like the most kind to its trainees, and it's a very long residency. It doesn't have great hours. And like, as much as I tried to love any other specialty, like nothing else could kind of come close to what I felt on my surgery rotation. So I guess that's kind of how I
That's really interesting. You tried to talk yourself out of surgery because it sucks.
Surgery does not suck.
That's not what you said. I definitely put words in your mouth, but you know.
I don't want to talk anyone out of surgery. I think the narrative going into medical, like in medical school, is that surgery does suck though, and like it's not a good lifestyle specialty.
I will say this: I feel like it's a polarizing.
It is a very polarizing
specialty.
thing. When I tell people
some
I'm going
people love it, some people are going to be like, it's not for me.
Yeah,
totally get that.
I feel like every specialty's a good bit polarized though when you talk to people, because like OB also not known for its great hours, also not known for being the kindest on its trainees. You talk to some people that are like, this is the thing that you should go into, this is great, this is perfect, and you talk to other people and they're like, why? And I feel like that can be pretty generalized. I'm sure everybody in the room has had some people say like, why do you want to do that? And other people saying like, of course you want to do that. That makes perfect sense. I don't think there's any specialty that I can think of that has just like 100%, yeah, this is a great specialty and everyone should go into it. I've always had that kind of push and pull from people.
Yeah.
And it's hard when you're in when you're in like in M2, M3, M4 shoes, and people that you look up to say those things about something that you like.
Including during clerkships, like people, like faculty will sometimes try to talk you out of the thing that you've chosen.
There's always the concerns of like AI taking over radiology, and
hear that a lot on Reddit or whatever. I was just seeing that this week.
Yeah, you can find it all over.
But
Reddit.
we've been talking about that on the show for years now.
Yeah,
like,
and
it's coming for you, whatever.
I think it'll still be quite far away. And honestly, my experience is the people who are saying it the most are typically not radiologists.
Yeah.
Every other radiologist you talk to is like, AI will actually help us with our jobs. Like, because there's still crushing amounts of volumes, like AI will honestly help streamline the process so we can read even more. But
from a non-medical perspective, totally agree with that. I am not, I mean, you know, I guess we'll find out. But also, like, I don't have the sense yet in any discipline, medical or not, that it's going to change things to the point where you don't need people. You know, it's just not there.
Yeah. So I had a family member who was in medicine try to talk me out of family medicine.
And what? How did they try to talk you out of it?
Yeah.
So I feel like I know. Go ahead.
Yeah. So the way they had described it to me was that it was a dead end, and that, you know,
okay.
And that, you know, the options for further specialization or fellowships are limited, and kind of in trying to advance your career, there's just a lot less options. And that was a bit hard for me to hear, because it was a family member that I had respected, or I still respect a lot.
That's the end.
And that's over now.
Yeah, but I think as med school went on, as I went through rotations, I think, you know, a lot of figuring out what specialty was right for me was less so about, a lot of it was like learning more about the specialty and like actually being there and experiencing it. But I felt like for me, it was as I understood myself more and understood what my personality was like, who are the types of people that I fit in the best with, what were my life goals. And so for me, I just found like through all my rotations, I found that I fit in the best with the people in family medicine, kind of the people that had a much more holistic approach, balanced approach to life. And that's very much my approach to life. And I'm someone who has a lot of different interests. When it comes to medicine, yeah, like I kind of enjoyed everything, but I couldn't see myself only doing one thing for my whole life. And in terms of my career, I'm kind of looking to be more balanced with like family time, having time for my family, having time for my hobbies. And I like medicine, but I'm not like, I don't want to do like heavy research. Like I didn't go into medicine for like the like researching the sciences and in medicine, but I went into it for people and building the connection. So that was sort of how I found family medicine to be a good fit for myself as I went through my rotation year.
I will say also that I've never gotten the impression that there is such a thing as a dead end specialty. I really think that you can do so many things in any specialty beyond what people think of as surgery or as family medicine or as radiology or as OB. Like, you can take it into, you can work with different populations. You can focus on, different parts of your specialty if you want to sort of drill down into it. Mm-hmm. You can hang up a shingle that basically says, I do this, I work with these people. So if you run into it's not officially specialization or subspecialization, but you can do that if that's what you want to do.
Yeah, absolutely. And this is kind of just my shameless plug for family medicine. Is like one thing I love about it that I've seen through my mentors in family medicine is that it's such a flexible and versatile specialty. My mentor kind of told me about her career path of starting out in a community at a community clinic, and then she felt like she was burning out a little bit, so then she went into just doing OB because she really enjoyed doing that, and she did that for a few years, and then like with life situations, like she had a kid and needed to kind of scale back on her hours, and in family medicine that's really easy to do. It's a lot more flexible, so she kind of went back into the clinic setting, did part-time until the kids got older, and then she went into academic medicine and wanted to do more teaching and working with students. So that was something that I loved about family medicine, that I think a lot of people, the people who say family medicine is a dead end, I don't think take enough consideration to is the flexibility that the specialty allows.
Raise your hand if you are ever told that you're too smart, or I guess maybe too dumb, to go into your specialty.
I was told I'm too nice. Does that count?
Yeah. Too something to go into your specialty.
I get asked, I get told this guidance basically weekly from some old guy being like, wow, you're so brave for going into OBGYN. It's like, I'm a white guy. I'm not brave. You don't have to pat me on the back and congratulate me for being a minority. Stop.
You're so brave. It's so weird. It's such a weird thing to tell people. You're too X for your specialty. Okay.
I don't know how to respond to it either, because they say that often, I'm like, all right.
I think it's often said by people who are trying to convince you that their specialty is the one to go into, right? Mm-hmm. I don't know.
Yeah, I think it comes from a good place ultimately, but it does kind of hurt in some way of being so there's this big stereotype that I don't fit in some way. So am I not good enough for my specialty? Am I not whatever enough for my specialty?
You are very nice, Mallory.
Thank you. But does that mean I can't be a good surgeon? No, I don't think so.
No, I think there's so many nice surgeons. I've met a lot of nice surgeons.
Yes, I agree.
Some could argue that there should be more nice surgeons.
Yeah. So Mallory, doesn't sound like you fit your specialty stereotype.
I don't know. I think there are certain things about surgery that I probably do fit some stereotypes in. I'm a very concise person. I get to the point very quickly, and I
love
think,
emailing a surgeon.
Yeah, it's
emailing a surgeon is like
2 lines max. Yeah. I tell you exactly
2
what
lines,
you need to know.
2 words.
There's no flowery things. And
Dean Cooper is a pediatric urologist. I email him and I get back a 2-word response. And I am sometimes grateful for this, because I don't need a whole list of things to think about. Just give me the thing.
Yes.
Thanks, Chris.
Yeah, so I think that's a stereotype that I kind of fit into. I think I'm also very detail oriented, which I think also you would want in a surgeon. I'd want the person who's cutting up and sewing things in my body to kind of care about the small stuff. That was really important to me. But I think in terms of the I don't like talking to patients, or I only like surgery because my patients are asleep. Like, that is definitely not true for me. Like, I, like Will, like, love the people aspect of medicine. That's why I went to medicine. And like, I think it's kind of different. It's a different way that you do it in surgery, but it's still something that's really important to me, and something that like I am like kind of emphasize a lot in my application is the like people person part of me. And I think like people brought that up in interviews and stuff too. So I don't necessarily think you have to be like the mold of whatever your specialty is in order to do well in interviews or in that specialty.
Still, it's fun to talk about this.
It is fun.
What about you guys? You feel like you meet the stereotype of...
Absolutely not.
What is the stereotype?
The stereotype of an OBGYN is like...
a woman.
Yeah. I didn't want to be like, yeah, the stereotype is like this tiny woman who's like the nicest person ever.
This tiny woman.
That's the stereotype. Yeah.
No, I love it.
And I am
a giant man.
I'm a giant man. And I actually wrote about it a lot in my personal statement.
Oh, did you?
Yeah, in the same way that it sounds like Mallory did. I wanted people to know that like I know that I'm not the stereotype, and I think that like I can still succeed even though I'm not the stereotype. And so like I talked about how I think the best way that I've heard myself explained is like a teddy bear. And I talked about that. I talked about like, yeah, I'm intimidating when I walk into a room, but once you get to know me, like I hope that you can see that like I'm really caring, I'm really nice, I'm really like approachable. And even though I'm not the stereotype of what you would expect in an OBGYN, I still think that I can be a really good OBGYN. So I really leaned into not being part of the stereotype during the entire process. Mm-hmm. I'm sure that, you know, there's some programs that either thought it was like too bold to say something like that, or like there was something else in my application that they just tossed me into the reject pile. But I do know that the programs I interviewed at, like every single one talked about that as a positive. Mm-hmm. And so I found like I was able to get a lot of really good fits on the interview cycle by saying like, this is how I don't fit the stereotype, and this is what I think I can bring to the specialty.
I think I've been told that I am totally fitting the family med stereotype.
I think you might. I don't know you very well, Will. I think this is like today is the first day we've really even laid eyes upon each other. I'm not really sure, but you've got a pretty solid, friendly, open attitude about you.
Thank you.
To me says family medicine.
Yeah, I appreciate that. But yeah, my closest friends in med school, they pretty much from day one, they were like, yeah, you're totally a family med guy. But yeah, I really like talking to people, and that was always the highlight of my time during rotations. Mm-hmm. And I think that's the case for most family med doctors, is they love.
Kind of would have to be successful in it. I mean,
absolutely,
it's kind of important.
Yeah.
Jacob.
I'd say I probably also fit the radiology stereotype.
Agreed.
Unfortunately, like the stereotype of like sitting in a dark room, like I already do that at home anyway. Like might as well get paid to do it as well. And just like liking study and learning, like I think that was the big thing for me. Of like, I still want to help people, but like I have the opportunity to do it in a different way and just constantly learn and use all my different clinical knowledge from all these different fields, kind of being able to impact care on like everyone in all these different fields. And I think that's pretty exciting to me. Yeah.
So going off of that, and talking a little bit more about especially our core year rotations, but any advanced year rotations as well. What are some things in your rotations, especially rotations that weren't the rotation that you actually like ended up going into, that you found really helpful in solidifying your decision? Also, I know that you hear all the time, like, oh, I went into the operating room and I realized I hate surgery, and so I'm never going to do that again. And so on this podcast, we don't want negativity. So obviously, if you have any of those, that's fine. Oh, okay. I don't want negativity then. But if there's any, like, what are some of the positives that you saw in other rotations that you were like, yeah, this is what is going to influence my career? So, for example, for me, not during my career, but much later on, I did a palliative care rotation. It was a 4-week rotation, and I loved it. I thought that I could really get to know patients. I thought that by talking to them, I could empower them with information. I could help them through really, really tough decisions. And I got a lot of enjoyment out of that, even if sometimes the decisions that were made weren't like on paper the happiest decisions. I felt a lot of, satisfaction in helping them make the decision that was right for them. And the entire time on that rotation, I was like, this is perfect for OBGYN. This is exactly who I would want to be as a doctor. If somebody's coming in that has to make a really challenging decision, whether it be about an abortion or a complicated pregnancy or something as simple as what kind of contraception you want somebody that is really, open to all the options, is able to give you information, but not make a decision for you. And so that's something that palliative care and OB don't like classically overlap outside of Dr. Elise Brock, who's both. But it's something that I went through that rotation was like, yes, this solidifies why I want to do OBGYN, and I can see how it applies.
Clarification? Do you think you're more OB or GYN?
I think I want to do a lot of both.
Okay. Yeah. Anyway.
So for you guys, whether it be something like that or something else, what are some things on other rotations that you saw that were like, yeah, this confirms my idea. This like really is something that I'm excited to take with me into a different specialty.
For me, I felt like, because I had entered into medical school kind of having an idea that I wanted to do primary care, but I was still very much trying to keep my mind open. And I don't think I really firmly decided on family med until my actual family med rotation during core year. But it was on my mind, and overall primary care was on my mind. So I think during core year, when I was going through the more specialized rotations like neurology, or even in IM when we do like cardiology clinic or the different specialty clinics, or surgery and OB, I found what helped me was trying to pay attention to trying to take a primary care approach towards those like more specialized fields of like, okay, what is like a baseline level of knowledge that would be good for me to know, so that in the future, when I refer patients, I would be able to communicate well with the specialists. And then also being in clinic, just like really trying to pay attention. Like I remember cardiology clinic, the attending I worked with was getting really frustrated on one day because all the patients he saw were AFib patients, or atrial fibrillation, which is something in his mind that could be taken care of by primary care providers. And for me, I was like, oh, wait, this is actually super valuable for me to pay attention and learn. And so in the clinic with him, I got to ask him a lot of questions about how to manage AFib. And so I think that process kind of confirmed to me that like when I was in the more specialized clinics, I felt myself drawn to more of the problems that were more common, and that the specialists were like did not want to manage. Yeah.
I help write the medical student performance evaluations, and one of the comments that I see often is, he admitted to me that he was not going to be going into this rotation, but he really did a good job of trying to find things in the rotation that could benefit him in his chosen specialty. And so people seem like that's good feedback. That's good. I feel like if you're gonna unfortunately you're gonna have to go through rotations that you're not interested in. Mm-hmm. So focus on the things that you can get out of those for your future career. And not only will you get good evaluations, but you'll also get some useful knowledge.
It's also way easier to care about. Like the amount of times that when I was on rotation and I had a patient that had things that I just not that I didn't care about, but things that I wasn't like going to use in my future career, it was a little bit harder to like go home and be like, let's study up on this. Let's do XYZ. But whenever I had a patient that had anything related to things that I might see in the future, or like Will said, things that they were like, anybody should be able to work this up. Like, why is it going to a specialty clinic? It's a little chance to be like, oh yeah, what do I need to know about this? So that way, like, I can not only be a good doctor to my patients, but also be a good doctor to my colleagues.
And also it's about, sometimes I think it's about reframing, as a student, it's about reframing what you're seeing as like, okay, yeah, this isn't my thing, but I'm here now. This is what I can take in from this experience and sort of,
Yeah. I'm kind of in the boat that like every doctor should be able to do certain things, like no matter what specialty you're in, like there is some like core competencies that like you should have as a doctor. So like I tell people all the time, like there are some people who are like, I hated surgery, like that was the worst rotation, I hate the OR, and I was like, okay, like that's really valid, but like you should know how to like suture. Like I think every doctor should be able to like know how to suture.
Yeah.
Like that's just like one of those things that like no matter what specialty you're in, maybe not radiology, if you do a biopsy or something, like I just think it's like in every specialty I went in and I was like, if I'm a good doctor, like what would I need to know? Even if it has nothing to do with my specialty, like there is something that you should know how to take care of as a doctor. And I think that's also a really important thing of like, yeah, maybe it's not like a surgery thing, but like we go through medical school and there is the curriculum that we have because there are some things that like you just as a doctor you should be able to do and know.
53 years old, I've gotten a lot of stitches in my life, and most of them were done by primary care providers, PAs, in primary care, things like that. So, yeah, good point. Let's move on for a minute to interview season. I want to hear about, I don't know, some things that were interesting about your interview experience.
I guess I can go first. So the issue with some specialties is like you have to interview like both your primary advanced, especially like for radiology, advanced positions, and you have to also interview for transitional. So like kind of like interviewing like two separate like specialties. So it can be
if it's not clear to listeners, a lot of specialties have a 1 year maybe transitional residency that they do. So that's like
it's like a general medicine,
like internal medicine. I feel like it's common. Yeah,
you can do surgery one too.
Yeah, you can do prelim surgery, preliminary medicine. Basically, it's just like.
And then the next part is you go. After you've done that, you go into sort of your
advanced
specialty
program.
residency.
Yeah. And so I guess for me, at least, I had a lot of interviews, and they were all virtual. And there's only so many months of interview season, so like. I was doing like 3 or 4 a week at one point, which it was a lot. And particularly with virtual interviews, I think like we're slowly making our way back to in-person interviews. I think surgical subspecialties are a little bit more from what my friends have said, but it's just kind of hard to keep things together. I think that's the big thing where like all these programs kind of sound similar. Like everything, the best thing about every program is the people, and like, I think a big thing is like just
Jacob's like, I'm a radiologist, I don't care about it.
I thought we were getting away from the stereotypes.
But like I think the big thing is like keeping programs, like keeping track of like what makes each program special. It can get very difficult, and just like coming up with a system to figure out like what particular about this program that I really like compared to some of these other programs. And
did you say you must have taken a lot of notes after your
I have like a 60-page document.
Oh my gosh.
That's a lot.
I didn't write a single thing down after any of my interviews. I ranked solely on vibes.
I mean, they're all going to be surgery. There
were pluses and minuses. I definitely think there were things that I thought were really important during the interview day. And then by the time I got through like all of my interviews, those things muddled. And so I was like, did this one have a night float, or was it like Q3 call? Like that. And I was like, that's kind of important for my life. Like I probably should have written that down. But I think a lot of like the things that when I was making my list of programs to interview at that I thought were really important, I like got there on interview day and I was like, actually, I don't care about that. Like I had, I think a couple programs where like there were some things said to me that I am not going to go into specifics for a bunch of reasons, but like I was like, I think the culture here would be horrible and I do not want to end up here. And that to me is so much more important than like how many weeks you spend on an away rotation somewhere. And so it's just like, I think balancing those things.
Yeah, I feel similarly. I, going into OB, most of the programs are a little bit smaller. Like I think the biggest program that I saw was one that had 10 residents per year. Most of the programs were more in that like 5, 6, 7 range. For example, Iowa here has 6, and where I'm going at Mercy St. Louis, this is their first year with 7. They've had 6 every other year. So it's a relatively small group, most of them in the 20s. And so you get to know the residents pretty well during the socials because usually most, if not all of them are partaking. And so you can see... participating in the social event.
You were saying they were drunk.
No. On a work night, that'd be pretty brave.
Yeah, that'd be brave. Yeah.
But I think that was cool. The other nice thing was since we didn't have transitional years, you could really focus in on that program and kind of see what would it be like to go from like year 1 to year 4 and kind of dig into it. But I completely agree with Mallory. There's things that I like wrote down as being things that were important to me when applying to programs that I just did not care about. Like I wrote down like everything, like the days off, weeks off. I wrote down like the hours of didactic sessions. And then I got to there and I was like, they're all kind of the same. I'm not going to choose a program based on like its location, like as in like I'm not going to choose a program whether it's in like a suburb or like a downtown area, or like I don't care about the commute really. Like that's not going to change my opinion in things that like maybe I thought they were. I wrote down notes, and then at the end of the day, even though I wrote down a bunch of notes, I solely ranked on vibes.
Yeah. Well, that's not unimportant.
Yeah.
You know, you got to live with this program. You know, you got to live with these people.
Yeah. We're going to be spending like a significant portion of the next like 4+ years.
Mm-hmm.
Like I want to be in a place of people that I think I'll like, and that I think like I'll be supported by attendings and other staff there. And that to me is like way more important than some of these things that I thought were really important when I was like looking and researching programs to begin with.
Yeah. And it's hard on virtual interviews to kind of get that sense. So I feel like if there were a few programs that had second looks, which I think helped a lot when coming up with rank lists to assess the vibes of the program. But yeah, I think overall, like if there is a choice between in-person interview and virtual interview, in terms of like being able to assess the vibes, like in-person interview would be like super helpful.
I agree. I had one in-person interview and all the rest of mine were all virtual, and like it definitely was a difference in terms of like seeing how the faculty and residents interact in a way, because you don't really get to see that on virtual interviews, or just like even just kind of seeing like the environment of like the support staff and the nurses and like all the other people there. Like that's like such an interesting thing that you cannot get from virtual interviews. So it was kind of interesting for me to be able to compare those.
What role did your mentors play in making your decisions?
I wouldn't have signaled my program if it weren't for my mentor.
So signaling is different in all the programs, so I'll be super brief. Yes, and very general. Yeah.
Signals are a way before, like when you're applying, so before you even get an interview, to say, hey, I'm interested in your school or interested in your program. It's kind of transitioning to where you almost need to signal to get an interview. There's some places that will send out interviews to people that didn't signal, but it's kind of like you have to.
Yeah.
You're
basically telling programs, hey, you're on my list of people I really, programs I really want to talk to.
You're on the short list, yeah. Mm-hmm. And, it was it was one of the last few to make it into my list of signals. Mm-hmm. And the biggest reason that I did is because there was a connection to that program from one of our previous med students who apparently went there, had a great interview, great experience, matched there, and is like loving it. Mm-hmm. And my mentor was able to say like, you should send them an interview because we've had great experience with this program before. And then I love my interview, and the rest is history, as they say.
That worked out.
So my mentor wasn't like, you should put them first on your list, or they didn't like kind of hold my hand through the entire thing. But my mentor was really nice in giving me just tiny little snippets of like, you should look into community programs. She said that really early on, and community programs are something that's kind of specialized to the more primary care specialties depending on who you talk to.
Well, community hospitals are different from academic medical centers.
Yes. They usually have limited to no fellows. They have a mixture of they have a mixture of providers that are there for like resident education and some that are private. They have usually some medical students, but they're not associated with a big medical school. So the one I'm going to, I think we'll have like rotating core year students, like a small number of those. And then also we'll have sub-Is and things like that. Kind of the difference in a similar way to family medicine being sometimes considered as like a lesser. Community hospitals are often considered to be lesser than academic hospitals by some people.
I think the difference is like you see a lot of bread and butter stuff at community hospitals, right? Whereas if you're in an academic medical center, you're probably getting people referred there that have more complicated or more complex needs and all that kind of stuff.
Yeah, there's a lot of
obviously
things.
I don't love the better or worse sort of ranking of
no, exactly
programs.
And
it's just what you want to do,
exactly. And so like when I was making my list, like community places might not be something that I considered highly before talking to my mentor about it, but then afterwards it's like I do want to see a lot of bread and butter. The places that I ended up applying to were places that also saw a lot of like tertiary care things and had some of the subspecialties, but were mainly focused at creating generalists. So I know surgery has a lot of community programs, primary care has community programs, but that was another thing that I had to think about when applying. And I think my mentor was able to give me that like early on, like this is something that you should really consider based on what you want to do with your career. And so that helped kind of alleviate some of the preconceived notions that I had about, the things that nobody likes talking about, but the things that get passed around anyways.
Yeah. I think what I liked about my radiology mentor is he was just very honest and open. Like, I know throughout med school, like sometimes you'll find staff, like everything's like all roses and like flowers and stuff. I don't know what I'm saying, but like
roses and flowers,
everything's in like a good light. But he was very honest to me about like, I've heard these things about this program, like it might not be great for training in this way, or like, oh, this program is really great. I know a bunch of people here that have done this and like they're good at this. And so just having an honest mentor, I think that's one of the most important things that I found for like both deciding rank lists, like where to interview, stuff like that.
Yeah. I think something that I found after talking with my mentor is that actually the networks among the different residency programs are actually pretty tight-knit and close, and
it's a surprisingly small world.
Yeah,
so
even
small.
among primary care, which is a big tent.
Yeah,
it's still kind of a small world.
And it's weird because we don't realize that, but there's so much stuff going on in the background that I still don't know about. But
you guys are going to be part of that background at some point.
I know. We get to know all the
shadowy cabal of
the secret society.
Yeah, but that's really helpful to be able to talk to them because they know people all across the country, and they know of different programs. They have people that they know and trust really well who are program directors at other programs or institutions that might not have the flashiest names, but the people in the people who know programs, in the know, like those programs have really good reputations of turning out super strong graduates. So I think that was something that was really helpful for me talking to my mentor, was just she had me submit my list of the programs I was interested to her, and she helped me look over it and just kind of basic check through for me of like, oh yeah, okay, these programs sound good. Like, oh, this one, like I've heard this thing about it. There's maybe like some concerns, which like doesn't rule it out, but just to be aware of. And then other ones are like, yeah, like these are solid. Like the residents there are really well trained.
I think kind of in that like secret network society that we don't understand, like my mentors did reach out to me to like the programs I was really interested in. If they knew people there, they would like reach out to like other faculty or other program directors. And when I was like in this like interview process or applying, like that felt so gross to me in terms of like, you have to use your connections. Like I want to get whatever position I have because of my own merit. But it's unfortunately one of those things that like, I don't want to say, oh, everyone else is doing it, so you should do it too. But kind of in the same way that we were talking about, like on paper, a program may look really good and then you get there and the vibes are horrible. Like I think programs really feel the same way about applicants. And so it is, I think, reassuring for them to hear from like a real professional that they know and trust that like, oh, like Mallory's a good person. Like I'd want to work with her. And so I think I still do not like that system. And like, I think there obviously is a lot of problems with biases and like privilege in terms of like, I'm lucky enough to have amazing mentors that are really well connected, that are willing to like reach out on my behalf. But it is unfortunately, I think sometimes, especially in like really small specialties, like surgery is not that small, but a lot of the surgical subspecialties, it's, I think, even worse. And so that's like something to keep in mind too in choosing a mentor is like, do you trust them enough to kind of speak to you on your behalf, or just like that they would be willing to kind of help you through that process too?
How did you find these people?
Our mentors?
Yeah. Did they just happen?
So
Is it organic? Did you like seek them out? Were you like, you're my mentor?
We get a list of people who are approved as mentors. I guess
Specialty specific faculty advisors.
Whatever the acronym is. SFA.
I only know this because I was literally talking about this with somebody in a meeting the other day.
But for me, I had my research mentor who is in family medicine, but she was not on that list. Because I think to be on the list, they get additional training. But then through my research mentor, she recommended people from that list. Well, she was like, everyone on the list is great. Like you would do well with any one of them. But I think the people on that list for us, like they're all people who want to help med students out, which is why they signed up for it.
They're self-selecting for that.
Most of my mentors I met through just like clinical responsibilities. Like I feel like as medical students, we kind of rotate and meet a lot of different providers on a day-to-day, and there are people that you just kind of vibe with more than others. And a lot of time, like if you show interest in their specialty, like they really want to like pour into you, especially here.
People like talking about their work. I mean, it's an important part of their lives. It's, don't underestimate that. I feel like if I was going through this process, I would be like, no, I don't deserve your mentorship. But the truth, but the truth is like, people like helping, especially in this profession, I think.
Yeah. So if you just like show interest in some way, I think, and kind of like reach out to them and continue to be in contact. Like I have like a couple people that I just like was in the OR with a couple of times. We clicked, we like got coffee afterwards and started talking, and like now I have their phone number and I texted them when I had questions about residency, and like it's just a really organic way of like mentorship, and also I think a great way of like, it doesn't have to be this like really like rigid program of like, maybe you don't vibe with, there were only 2 surgical SSFAs. So if you didn't vibe with either of them, like I think there's a lot of other opportunities to like create mentorship or like meet someone in a more organic way.
Did you get any of you have trouble coming up with somebody to talk to about it, or was it like these guys have said?
I think I got really lucky in that my primary mentor was one of them that was on the list. And I think that I always got good advice, and like the kind of advice where I left and I was like, I had this really good idea, and it's like, no, I didn't actually have the good idea, it was her idea, but like she said it in a way that was like, that was my idea, which I always vibe more with. I don't like being told things, so I'm gonna have a really fun next 4 years. And so that was cool. And I think I was maybe slightly different in that I have a lot of other mentors that are just helping me be a really good, like at least hopefully to be a really good doctor, people that I work with a lot. I'm doing like a continuity of care clinic, and I consider the doctors I work there to be like really, really close mentors, but I didn't ask them about my process. I kind of mentioned who I was interviewing with, and they gave some of their opinions, but I didn't ask them to like review my list of places I was gonna apply to. I didn't ask them to review like my rank list. I kept all that really close to the chest. And I don't think there's necessarily a right or wrong way to do it, but I was also like, I'm keeping it close to my chest. I'm not really like sharing it with everybody. I just want it to be like a couple people that know, and that's kind of how I went about it.
I honestly didn't really talk to my SSFA that much besides like the required. Like my mentor that I'm closest to in radiology, I met through research. I actually just like tried to find a research project and found him, and he was great and had a lot of good things to say, and I really appreciated his knowledge. So that's kind of how I met my mentor, just through research.
Okay. Well, as you look back, I want to know if there's stuff that you wish you'd known earlier about this whole process of finding a job, finding a specialty.
I think the thing I would have told myself when I started was just like continue to continue to be open-minded, even throughout the interview process. I think my journey, the programs that I thought I would be most interested in, or even the location that I thought I wanted to be in, at the start of when I first applied, was not the same as after I interviewed and after I submitted, and when I submitted my rank list. Because I'm from Southern California, and I thought I wanted to go back home. And thinking about residency programs, I thought like, residency is going to be hard enough. Like maybe try to pick one that has like just the best work-life balance and like maybe like the cushiest program. That in my mind, that was like the way to go. But as I looked at programs and started interviewing, I ended up, this is a super long story, but like short version, like I decided to get a dog, and I picked up the dog in Denver, and kind of fell in love with Denver. And
Without the dog, you would never
have
considered Denver.
And like, like fast forward now, like I ended up applying to a few programs in Denver, but still with the thought that like I probably end up in SoCal, like wanting to be back closer to home. But as I ended up getting all the interviews from the Denver programs, and then I ended up not getting nearly as many interviews from programs from back in SoCal as I thought. And so it kind of came down to like 50-50, like, but then as I actually talked to the programs, looked into it, interviewed with them, the programs in Denver, I felt like I just found myself thinking like, man, I would feel so lucky to be here. I feel like the training they would give me would be really robust, and I would come out of it just a super well-trained, like strong physician. And not to say anything about the programs in SoCal I interviewed, like they were also really great, but I think I just found myself like really surprised by like how excited I felt about the programs in Denver. And then I ended up ranking all the Denver programs at the top. So
it's weird to say that your dog was your mentor, but that's kind of what's happening here.
Yeah.
Your dog just wanted to go back.
So all that to say, like, I think
What's your dog's name?
Her name's Manna.
Manna.
Mm-hmm. Like manna from
heaven.
Yes.
Amazing.
Yeah. But yeah, all that to say, like my whole residency application and interview process did not look at all like what I thought it would. But I think now after going through it, it was really nice. I think, just being open-minded and realizing that a lot can happen even throughout the application and interview process. And you end up learning a lot more about yourself and what you actually are looking for.
Jacob has to leave. He's got to go do some important radiology work. Thanks, Jacob.
He has to do his favorite thing, which is talking to other people. Kind of going off of that, I think that keeping an open mind during the entire thing is something that's really helpful. I already talked about it a little bit, but I kind of had always assumed I was going to do like an academic program, just because I was an academic program and I thought that I was going to do an academic program. But I was able to keep an open mind. My mentor was like, apply broadly. And I ended up applying broadly, and I really fell in love with a lot of the community programs I interviewed at. And I feel like if I would have had preconceived notions or just like a bias against it before going into the interviews, I think I would have ended up in a different spot. And I think like, especially for people that may have been more interested in like name brand programs. I heard somebody use that before, like designer brand schools, I think is a fun way to describe it.
Yeah.
But if like you get too hooked on that, I think you might miss a better fit. And so that was something that I'm really fortunate that I was able to keep an open mind and really like go into every specialty or every interview being like, I think that this is the place I want to be, and really give every place I interviewed at the benefit. And I think that that was helpful in the long run. On the other side, not on the other side, but the other piece of information, the other piece of advice that I would give to myself that I guarantee you I would not have accepted when I was, an M1 or an M2, is to say like, things are going to be fine.
Yeah.
I think that there's a combination of advice that I got from either more senior med students or advice that my friends got from more senior med students that kind of fit in two different buckets. One of them was you have to honor everything. You have to do everything. You have to do research. You have to volunteer. You have to do XYZ. You have to get a good score on STEP. You have to do all of these things. And on the other side, people will individually say like, you don't need to do that well on rotations. You don't need to do well on preclinicals. You don't really need like two very extreme buckets, and I've heard both of them.
Mm-hmm.
And so I think one of the things that I want to stress to everybody, and especially like the younger med students, that it's gonna hopefully be just one more drop in the bucket of people saying this, is like, yes, you need to be better than like, you have to have things. You have to like have things that you can talk about and be passionate about on your interview, but you don't need to be perfect. Mm-hmm. You don't need to score like a 260 on step 2. You don't need to honor every rotation. We will take stumbles. You do not need to be perfect to still be excellent or great or good.
I love that. I think that's very important to say.
Yeah, I agree. I actually failed a class. And so I was like, there's no way I could be a cert. Like when that was happening,
Which
I was
class?
like, I'm not going to.
Come on. No, okay,
I failed. I'm happy to. I don't care.
No, you don't have to.
Okay. Jacob's gone. I failed the radiology clerkship. And I remember what happened.
Is
I
it
was
a
like,
shelf thing or?
Yeah, it was a shelf thing.
Yeah. Those are hard.
They are hard.
Yeah.
But I was like, I'm never going to match now. This is the end of my like I've wasted all this.
I see this so much on Reddit. Like people are like, am I cooked?
Yeah.
Got a bad eval. I'm like, no.
I remember like talking to my mom and I was like, I'm never going to match. Like I just wasted
by
all
the way,
this.
that would be me too.
I know.
Like,
I
am a huge catastrophe.
Yeah, and I feel like it's a very like medical students in general. Like we are all very perfectionists. We all really thought all these things. Like
but then you're also told stories about stuff like that. Like it's a common story. Like, oh, you got to do awesome and everything.
Yeah.
Well, the other hard part is like I know of people that I'm close to that did not match.
Mm-hmm.
And so like I want to say like, yes, we have room for failure, but also like it is hard.
Yeah, it's hard, and it's also kind of a numbers thing a lot of the time.
It's much more of a reflection of the system than the person.
Yeah.
Like there's a very big problem with the way that we like decide what your job is going to be for the next 3 to 7 years.
Mm-hmm.
And unfortunately, a lot of it doesn't matter. Like I wish that evaluations and people saying like XYZ about me were what mattered, but then you have the issue of bias and the issue of like some people are just like easier to write about than others, and like that goes into a whole thing. I wish that it wasn't like some programs would just take you out of the running if you didn't have this step 2 score. But that's how it is. And I think that that's also a really hard part. to say like, is the difference between like a 245 and a 246 that extreme? Probably not. Is the difference between a 239 and a 240 important? Absolutely, because a lot of schools have a cutoff of 240. And so that's also like one of the really hard parts.
And if you look at the data for it, it's like with a 10 or I can't remember if it was like 10 or 15 point difference, it's like still within the like
margin of error.
Yeah. And it's like, well, okay, like if we're like, yeah, we're really big into research and like significance and stuff, but if you look at that, that's like not that significant between like a 230 and a 245.
Yeah, I feel like unfortunately you give people numbers, they'll use them, even if they're not appropriate for that use.
Do you think that step 2 has any bearing on how good you'll be as a clinician?
No, I don't think so.
Anything you didn't learn or demonstrate in step 2, you're gonna learn.
Yeah.
I feel like
you're gonna practice it. You're gonna learn it. Like long term means, I feel like it doesn't mean that much.
When I was taking step 2, I felt like most of the questions that I struggled a lot with were like what's the side effect of this medicine? And it's like, number 1, I'm not going to see this medicine like at all. And number 2, if I do see this medicine, I'm going to look it up. And so like that part, like trying to study that was just impossible. It was like nails on a chalkboard whenever I read something about medicine, or like different medications, which I know will make all the pharmacists out there hate me, but whatever. That's their job.
I was going to say, that's what the pharmacists are there for, right?
Yeah.
Like,
and so like that part just made me mad. And like when thinking about it, it's like, why does an orthopedic surgeon need a 265? Like 5 years out of training, ask them to take step 2 again and see what they get. Like if it really matters, then they would get a better score.
Get
Where's
on that
the research?
World. Yeah, I want to see that.
Yeah.
How do doctors do on step 2? Because I'm sure that most of them do real bad, and they're still good doctors.
Yeah, I think that like, to me, step 2, or when you're doing tests like these multiple choice question tests, like what you're testing and what you're evaluating is like how well can someone study for a test. Which I mean, I still do think there is value in that like in the profession that we're in, like we do need to be good at, like we need to know how to learn and how to study and how to keep up to date with new research and knowledge. But it's just on a different plane with evaluating how good of a clinician someone is going to be, like especially with like your clinical skills, your like people skills. And so to me, it's just like I think the approach that a lot of students take when they kind of take this all or nothing approach of like, yeah, like step 2 or these test scores are going to be the main decider of like how good of a doctor I'm going to be, or like on my application, it's going to determine everything. But really, like that's not the point of these tests.
These are licensing exams.
Yeah.
That's all they are. Like they're being, I don't know, from my perspective, and I don't know everything about this, but I do feel like I've read a significant amount that says it's not appropriate to use a licensing exam as a cutoff for anything.
Sell that to residency programs.
I know.
Well, it makes
like I
their
say,
job
you give them a number,
easier.
they're going to use it.
Yeah. It's like, I mean, going into med school, there were like every single year you can check, I'm sure you can check Iowa's Instagram. It's every single year. The things that they post are the average age, the average GPA, and the average MCAT. Maybe like a geographic distribution, but like that's what they pride themselves on. Yeah. And like, I mean,
well, you got to keep in mind that these things are posted by non-statisticians also. So, you never see the standard deviation or the error bars or anything like that,
And so like, I think one of the other things, and I know I promise I've said this on the podcast before, is at the end of the day, an average is an average. Yeah. Half of the people are below average by like statistics.
By definition.
And so like, it's hard because like there are some cutoffs that are like the average, I think for step 2 somewhere around 247, 248, which means that half of medical students get below that. Some cutoffs are higher than 247 or 248. And other times, the cutoff might be 240, which is below average, 230, which is like further below that. But there's still like good medical students that just in the bell curve have those scores. And so, on one side, it could make or break an application. And on the other side, it's just another piece of information. But I'm not going to lie to you. When I saw my step score, there was like 30 minutes where I thought the world was ending. And then I was like, oh, wait, I'm okay.
Yeah. It's hard.
It's hard.
You get those numbers and it feels like a summation of you.
Yeah, especially while you spent like the last 2 months like only working on that number, right? Like you did dedicated, you like sold your soul for that.
I don't know how you guys, honestly, I don't know how you guys do it. It sounds like the worst.
I was really afraid of not being able to be employed. And so that's a really great motivation.
I know we asked about doctors, but today, say that we were told that we're going to take step 2 in a week.
Yikes.
Could we pass it? Like if we sit down and try as hard as we can, do you think that we could
cold, like no more extra studying?
No more, we get enough time to get a good night's sleep beforehand. Do we think that we can like either pass it or get above cutoffs?
What is the passing score for step 2?
I think it's like a 215. I don't know.
I think it's a 208.
208?
Yeah,
sure.
I think.
Hang on.
Dave's quickly Googling, guys. It's all right.
AI says it's 214.
Oh, okay.
Sure.
214?
All right.
I think I'd be pretty close to the cusp.
I think I'd be a little stressed if I'd pass or not.
Not feeling confident about this one.
Not because I don't know clinical medicine. I still do know clinical medicine, but it's like the weird, like very minutia things that aren't really that important, but like do differentiate like a 260 from a 250. Like
I definitely wouldn't get a 230.
Give me a week with divine intervention, though. It's another podcast that
it'll come back quick, I think. And we're saying this, but we will all have to take step 3, which
that's a good point.
Is something like
What do you know about step 3? Is it?
It's a 2-day test. You have to take them back to back, and it's pass fail.
What's the sub?
No, you get a score.
What?
Yeah.
I thought you just had to pass it.
You do just have to pass it, but you do get a numerical score.
But the score doesn't.
It doesn't matter.
Nobody cares about the score.
Yeah, but you do like get
Unlike
a number.
now, you're like,
why?
I don't know. I didn't design it. I'm not that important yet.
Mallory, fix it. But what's the is it just the same as step 2 but more?
I think so.
That's what it sounds like. It sounds like it's pretty like internal medicine based. Mm-hmm. So like I've heard a lot of like especially surgical specialties say like do it immediately because you're going to forget all of it. Yeah. Where I've also heard people in like primary care or like especially internal medicine say like you can take this later on because like you'll know it all by the end of your training.
I think that's really hard for like peds people because they just like they forget all of adult medicine during their residency and then they have to take like an adult medicine, mostly adult medicine steps.
Yeah, my dad's a radiologist and apparently he moved states and to get recertified, like he was able to get by this, but to get recertified, he had to take some like standardized test. Like, I don't know if it was a step 3 or something else, but he had to take some standardized test. And he's like, I'm a radiologist. I don't know any of these medications. Like, not only do I not know any of these medications, but I don't care about the medications. I'm a radiologist.
Seems a little dumb.
I know. So he did like, I think that he was able to get around it. But like, anyways, like that's kind of what they're telling us to do is we have to take this like generalized exam to, I don't know, prove that we're still doctors, just to forget about it when it actually comes to being the specialty that we are.
Yeah. I guess for better or for worse, that's what step 2 is for, to like prove that you can take a test because we're going to have to be doing that for the rest of our careers. Mm-hmm. Like I know it's like we'll take boards and then I know like every year for surgery, there's like a test that you have to take, like a standardized test as well. So like as much as it sucks, it's like
these are evidence that I have chosen the best path for myself.
You don't want to take a yearly test?
Hey, I find my annual performance review shattering enough.
I think for next episode we should make you a test and just like have you go through the stuff that you should have learned.
Let's do clinical skills. I feel like I could do okay on that.
Well, step 2 used to have a clinical skill part and they got rid of it.
I know.
Yeah.
I don't know that I could, say anything useful
not like
about
a medical. We could just make you a test about stuff that you should know, like as your job as a podcast host. And
I don't like that, but okay.
I wouldn't be mean to make you know medical things.
But it's going to be super minute stuff.
I think it might be. It's like, how much have I absorbed over the years? How much have I osmosed? Mm-hmm. I feel like
you picked up a lot of jargon.
I have jury duty coming up next week, and we'll see. And for some reason, I was thinking like what kinds of questions would be asked of you. And I was thinking like, okay, what if it's a medical malpractice case? Or what if, like, would they be like, how much do you know about medicine? And I'd be like, well, more than an average person maybe, but very little.
I know what Reddit has to say.
Yeah.
That's all that matters.
I know generally what a statin is.
I know, it's like there's people that know nothing about medicine. There's doctors and like other healthcare professionals that know a lot about like a specific type of medicine. You have patients that know a whole lot about whatever they're going through. And then you have Dave. Who's like, I don't know, people show up and they like say things and sometimes it sticks.
Yeah. Well, before we go, I did get something back from last week's listener questioner. I'll go with that. Arm had asked us whether she should ditch the school she got accepted into because she worried it sucked after getting into it. We basically encouraged her to stick with it because she'd have trouble explaining that when she went to reapply. And she sent us an update. Hi, I wanted to send you an update on my decision. The advice you all gave me was really helpful and ultimately supported my decision to go to medical school. To go to the medical school I got into. After speaking with a student and learning of their great match rates this year, I decided going would be the best choice. Thank you for all you do. So thanks for the update, Arm. I really appreciate that. Keep us posted on, how things go. Love to hear from you.
Let us know your step 2 score.
Let us know your and then
where you match into.
Where you match, because you're gonna do great.
We'll be sure to judge you along the way.
Yeah.
Good luck.
Yeah.
It's exciting to start medical school.
Well, that's our show. Matt, thanks for putting this together.
Of course. Thanks for being a part of it.
And Mallory, Jacob, who left, Will, thanks for hanging out with us today.
Thanks for having us.
Yeah, thank you so much.
And what kind of dumbass would I be if I didn't thank you, Shortcoats, for making us a part of your week? If you're new and you like what you heard today, if you're new here and you like what you heard today, follow the show wherever fine podcasts are available. The show is made possible by generous donations from the Harvard College of Medicine student government and ongoing support from the Writing and Humanities program. Our music is by Dr. Vox and Catmosphere. I'm Dave Etler saying, don't let the bastards get you down. Talk to you in 1 week. Hi, Shortcoats. Look, life in medical education, life in America, life in the world is often difficult. And I often wish I could help. All I have is this podcast, but in my wildest dreams, you have the support you need to lead a life of your choosing. You deserve to be happy, healthy, and successful in whatever ways you define those words. So if you need support because you've experienced racism, discrimination, harassment, mental health crises, I want you to be able to get the help that you need. And so I'm going to put some links in the show notes to some resources that you can use. But the bottom line is that for what it's worth, I see you. I know you're out there. I wish I could do more. Maybe I can in ways that I don't understand yet or know about. But I see you, and I'm glad you're here, and other people are too. This Shortcode podcast is a proud member of the MedEd Media Network. Inspiration, information, and guidance on your journey to medical school and beyond at mededmedia.com.